My name is Barry Gent and I was diagnosed with prostate cancer in November of 2015.
I'm Helen Gent and I'm Barry's wife, and we've been happily married for 24 great years.
Today on Health and Family, we visit with Dr. Ricardo Rendon to learn more about non-metastatic castration-resistant prostate cancer, or nmCRPC, a critical time within the prostate cancer disease journey between the localized and advanced disease state.
Whenever someone is diagnosed with prostate cancer, our first step is to try to figure out whether they have a disease that is contained to the prostate or whether it is growing just outside of the prostate. So when the prostate cancer has gone beyond the prostate, that's what we call metastatic disease. When we're treating prostate cancer for localized disease, we're always aiming to try and eradicate the prostate cancer. So this treatment for localized prostate cancer usually includes surgery, which is the surgical removal of the prostate gland, but it can also be radiation.
Prostate cancer, PCA, is the third leading cause of male cancer mortality in Canada, although survival has been improving over the years.
So I was diagnosed with prostate cancer in November of 2015 and I had my prostate removed, and after that for a couple of years I was monitored with my PSA and it stayed pretty low, under 1, for a couple of years, and then it did start to rise.
So the best way to follow our patients is with a PSA. So as the PSA starts to go up, we start to worry about the patient having regrowth of the prostate cancer. At some point, if the patient has a PSA that is going up after primary treatment, that means that it's cancer, and we're going to start ADT, or lowering the testosterone.
And then it did start to rise, and after about another 3 months after that I was put on the Lupron shots, and I had Lupron shots for every 3 months, and the PSA went down again, pretty low.
So what we see is the patient has a high PSA, and as we treat the patients with lowering the testosterone, then the PSA goes down. But unfortunately, the cancer cells will eventually learn to live in an environment with that low testosterone or low male hormone, and they will start to reproduce again.
The only time I really got concerned is when it started to shoot away. Even though I was still having the Lupron shots, it was shot away up to 6.5, and that was a bit concerning for a little while.
But there are other tools that we use, and one of them is the PSA doubling time, and that's when we see how fast the PSA is going up over time. And when we see the PSA go up, that's when we do x-rays again, usually a bone scan or a CAT scan. For patients who have non-metastatic castrate-resistant prostate cancer, up until 2018, the treatment was with continuation of hormones until they developed metastasis or spread that was visible on a bone scan or a CAT scan. So in 2018, there were 3 studies that were done using 3 different drugs. They're called ARADs. So these are drugs that directly attack the androgen receptor, so the testosterone doesn't go into the prostate itself.
Well, Dr. Rendon said the new therapy would be another way of controlling the testosterone in my blood and knocking down the PSA, and I must admit it was very successful, from taking it from about 6.5 down to a month later it was 1, and now it's well below, it's 0.08 now, my last test. So I was confused about, I had to continue having the Lupron shots as well as the pills I'm taking as well.
Frequent question is, if the cancer cells have now learned to live in a low testosterone environment, why do we keep using these ADT treatments? So not all the cells have learned to live in the low testosterone environment. So when you have a prostate cancer, you have a prostate cancer with billions and billions of cells, but not all of them are as aggressive. So we keep treating the ones that are less aggressive, that haven't learned to live with low testosterone.
Barry and Helen are living full lives, rising at 3 a.m. to tend to their animals in extensive gardens. Life hasn't changed for them much since Barry's diagnosis.
Well, I'm very lucky. I work about 3 days a week now, and that's a hard physical job. There's lots of walking around and up and down steps. Really, it hasn't impacted my life major in any way, shape or form.
And I've noticed that too. It doesn't make any difference. He's as active now as he was before. He can just work around much younger people than himself. We're pretty active people. I don't pull the old card, you know?
For more information on nmCRPC, please speak with your healthcare professional or visit the website below, procure.ca.